Well, hello, everybody. Welcome back to our B School, Be Better, Be Empowered. I am Dr. Emery Pitcel.
And I'm Rebecca Hall.
Flattered to be joined with you again today. Thank you for taking the time to, record with us and to share
Absolutely.
valuable information with the whole patient population out there, right?
Yeah, absolutely. I'm excited to be here.
Yeah. Can you believe it's April already?
Oh my gosh, time
Yeah.
flies.
Yeah. April of 2025. You and I were kind of talking, and we felt once again that it's another time of year where people just ramp up their activity. And so we're going to pick on one guy that likes to get inflamed when it goes from 0 to 60 too fast. And that's
hmm
like the plantar fascia, right?
Absolutely.
Right. So should we just dive right into the info
Let's
here?
do it. Yeah.
Yeah. Episode number 8. Crazy that we've been doing it that long. This is your second time on. I want to
Yep.
thank you again for being here.
hmm
And we're going to start breaking down the plantar fascia, kind of a bit of an overview, what kind of issues go wrong at it, and then build out from there. So, how common are issues in the plantar fascia? Well, according to NIH and like the CDC, we're looking at about 10% of the US adult population has some sort of incident with plantar fascia at some point in their life. Typically, now this isn't a hard fast rule. If you're thinking like I'm outside of 40 to 60 years old, I can't have plantar fasciitis. Oh, you absolutely can.
hmm
But most of the cases are going to lie between 40 to 60 years old. And in fact, I think they were finding, and there was like podiatry literature that was suggesting that 83% of cases are typically in people that are predominantly active,
hmm
either an active job like construction or what have you, or like an active athlete. But that still leaves 17% of the inactive cases that could potentially have a plantar fascia issue. So it's not one of those, ooh, I can wipe the sweat off my brow. I'm inactive. I'm not going to have a
I'm in the
plantar.
clear.
Yeah, I'm not going to have a plantar fascia problem. You still can.
hmm
And yeah, otherwise, the final thing is yes, it can occur on both feet at the same time. Apparently, that's about 1/3 of cases. So, still the majority is going to be unilateral, one side at a time, but you could definitely still have issues on both sides.
Yeah, definitely.
Yeah. So, anything you want to add as far as epidemiology and like, incidence prevalences?
Yeah, I mean, really, I think most of my research has kind of shown the same as what you were thinking. I think I had one source in the Cleveland Clinic that says basically 1 in 10 adults is going to get it at some point in their lives.
Makes sense.
Yeah, which is super fun. But yeah, it just makes more relevance to what we're bringing to the table today. So
Yeah, yeah. So if we're saying about 10%, I think it's really important that we then unpack what are the causes of, like, what are some of the most common causes that create a 10% incident in US adults?
right, yeah, and I think that's a great kind of turning point here. So a lot of things that I see, obviously on my side of things, right, massage therapy and athletic training, um, the a lot of times the plantar fascia just doesn't get tight by itself, right? It's not just going to be like one day, like, you know what, I'm just going to get irritated. That sounds like a fun time, right? Like
Right.
it's usually because of a couple different things. So one, change in gait mechanism, either because you're increasing your activity levels or you're doing something that you haven't done before or your body's not used to the loading, right? An increase in acute load without a chronic load baseline, right? So that's
Hmm.
kind of like your standard person that's like the couch to 5K in 2 weeks instead of trying to do a more gradual build up, right?
Yes, absolutely.
So that's one thing that I see. Another thing is shoes. I feel
Hmm.
like really affect your plantar fascia. I know I'm speaking from personal experience. If I wear shoes too long, I'll start to get an irritated plantar fascia. And I actually had plantar fasciitis on both feet in grad school because I did not change my shoes frequently enough,
Hmm.
and
Yeah.
it really affected me. And the second that I got better support, amazingly it went away. So that's definitely another thing. And then the third thing, obviously, is looking at the actual body and the structures in the body and how that mechanism works. But I think calf tightness and lack of dorsiflexion, lack of mobility, anything like that can be a really big stressor on the plantar fascia because that tendon from the calves connects directly into that plantar fascial line. So if you have too much restriction in that joint or those muscles, it's really gonna affect those causes of pain. I don't know if you have anything else that you've seen as well.
Yeah, yeah. Well, I think I want to add a little color commentary to some of the things you say. Definitely, it's so important to ramp up your physical activity, right? If
Mm-hmm.
you haven't, if you're that type of person, even if you're in like your early 20s and you're like, I used to go from, zero fitness to just running 3 miles like nothing. Yeah, you might be able to get away with that for a while, but then you get closer to like 30s and 40s, jumping all the way up in that activity, that repetitive pounding and load on the plantar fascia, it might be too much, right?
Mm-hmm.
You said shoes. I think really allowing people to understand what their foot structure actually is and
Right.
whether they actually can get away with, because most people could wear a neutral shoe and do
Mm-hmm.
just fine, but other
Absolutely.
people have flat feet and therefore they overpronate. And so being in a structure support, but then we also have the people that have too rigid of an arch and they kind of spend more of their time walking or running on the outside of their foot, and
Mm-hmm.
you still want to then therefore have a shoe that actually allows, at least for on impact, a little bit more room for the arch to actually collapse, so that way the shock doesn't just go up into like the knees and the hips.
Right.
I think the over supinators less likely to have a plantar fascia problem. We're
Mm-hmm.
kind of thinking the more guilty culprit here is going to be the overpronators,
Yep.
but it could still happen.
Absolutely.
And then just to kind of add to, because I was a distance runner in college, right?
Mm-hmm.
And our coaches harped on us all the time, 400 to 500.
Yep.
Once our shoes got to 400 or 500 miles, our training shoes, they had to be swapped out for new shoes.
Mm-hmm.
So not only just like the proper support and structure for your foot, but also the volume you're putting on shoes. And also buyer beware too. It's not just the total miles, it's also the time as well too. So if
Right.
you're like an avid runner out there, an avid tennis player, and you've had the same pair of trainers and it's like this is the second or third year, you're actually really supposed to swap them out after about a
Absolutely.
year, because even if you barely use them,
Mm-hmm.
material still breaks down over time. And so, 12 months later, that material is not going to have the same elasticity and the same rigidity that it needs to have. And so it's not going to support your foot quite the same way.
Right. And that goes for not only just activity shoes, right, but just any shoes in general. If you're
This is
walking
true.
around wearing them in a daily life
Hmm.
and they're, you wear them on a daily basis, it's still going to wear down even if you're walking to and from the office, right? And you're walking around your office in a day. So
I
definitely
agree.
relevant in a lot
Yeah.
of aspects as well.
Yeah. Yeah. So I want to jump into our next topic, and this is the question of where is the pain. Now I know usually when we say this, the obvious thing is plantar fascia. It's going to hurt on the bottom of my foot. It's a little more complicated than that, right?
Mm-hmm.
So if we're thinking like a kind of like a true plantar fasciitis, the pain is going to be more closer to the heel itself.
Yep.
However, you're still going to have like a lot of tightness and a lot of pain that also migrates its way up into like the medial part,
Mm-hmm.
and into like the arch part of the foot. A lot of times, what we're going to see, and the reason why we ask the where is the pain, is sometimes it's not necessarily registered as heel pain right away. Sometimes the first initial warning signs are that these calves feel really tight.
Mm-hmm.
And this could be tricky because sometimes was it the chicken, then the egg, or was it the egg, then the chicken?
Mm-hmm.
What I mean by that is, did you start with calf tightness that you left unchecked for months on end and it eventually did just overload the plantar fascia and give you like a plantar fasciitis presentation? Or was it that you had like a kind of like a brewing plantar fasciitis that was asymptomatic, but the injury and the inflammation and the irritation was starting to get in there, but then the calves are tightening up in response? Usually in office, what I say is I don't really care which one came first. They both need to be co-treated together.
Mm-hmm.
And then obviously, if the calf gets tight enough, that can start to keep like that knee in a little bit more of a bent position. So we start to potentially get into knee issues along with plantar fascia issues. Um, Certainly, that is entirely possible as well too. And then there is like a little tunnel that passes back behind. There's like this ball in the foot, this little ball part on the on the bottom of your ankle. That's called your medial malleolus. Right behind it is this thing called the tarsal tunnel. So if you do really leave a lot of calf tightness and plantar fascia tension unchecked, and it does possibly compress the tarsal tunnel, then
Mm-hmm.
you can start to see a presentation of tarsal tunnel syndrome, and then that's a lot more kind of pain and potential weakness accompanied with the foot and ankle complex. Um, so that was kind of a large tie-in. So it's not just simple on the bottom of your foot. We want to kind of just try to paint in the whole picture
Right.
of how many areas this can touch and where pain and presentations can also pop up, right?
Yeah, definitely.
Yeah,
And just adding to your tarsal tunnel comment,
correct.
that if you have a really flat arch, right, and your arch flattens a lot, it's going to put a lot of stress not only through the tarsal tunnel, but up into kind of your more medial muscles so the muscles on the inside of your leg, right? And that can lead to a lot of what people call like commonly shin splints, that medial tibial stress syndrome.
Yeah, right.
And that's another thing that can really be kind of affected if you let, these muscle tensions and these, I guess, joint play or lack of joint play just kind of continue. A lot of other issues can stem from it.
Yeah.
So.
Yeah, for sure. I absolutely agree with that. So we were already alluding a little bit to some common complaints, but talk through like some of the common complaints and kind of common symptoms that people are going to pop up that gives us all like kind of the flashing red lights to say we've got a problem in the plantar fascia.
Yeah. So I think a couple big ones come to mind. So my biggest key when someone comes to me is like, yeah, my foot's kind of been bothering me. I'll ask them what time of day it bothers them the most or when it bothers them the most. That's usually one of my first questions. And if they tell me it's right when I get up in the morning, it hurts so bad.
Yeah.
And then as I work it out and I walk around, it gets better. But if I sit for a long period of time, it's going to get worse again, right? That's usually a key to me that's a plantar fasciitis that we're dealing with, right? Because as that fascia will stiffen up when you stay in the same position, and then it tightens down because when our bodies are relaxed, if you have those tight muscles and that tight fascia, it's going to relax in the most comfortable position. And I guarantee it's not with your toes up. That's
yes.
So when you then pull your toes up, all of that's going to stretch, and that's going to really, really hurt. So that pain at that heel, it can also radiate into your arch. I've had a lot of people on like the inside of their arch really hurts really badly. Pain with walking, especially with that push off, right? So your toe off,
right.
Because you're getting into that mechanism that's actually going to stretch that plantar fascia, which we call the windlass mechanism. So that big toe pushes off, and that stretches that plantar fascia and tightens it down, which is a great thing for us when we're trying to walk and run and everything like that. But when you have a really tight plantar fascia, it then affects that as well. Calf tightness is another one that we already touched on, right? So that tension not only in the gastroc, but I notice a lot in the soleus. We were kind of talking before this about how much we think that is really a big muscle that affects it because it's a little bit deeper, it's a little bit more distal, so closer to that ankle joint, and it really can kind of, people are really good at stretching their gastroc, they're not so good at stretching their soleus, and that a lot of times can contribute to that as well.
Yeah, and I believe you're going to demonstrate technique, and we're going to have that posted to socials and YouTube for this month of April here, right?
Yep, absolutely.
But it's actually wild. It only takes a small change to change the difference between stretching the gastroc versus stretching the soleus. We're going to keep those cards to our vest for the moment, though.
So stay tuned.
Yeah, absolutely. Liked a lot of the things that you said right there, all extremely valuable information. I think another thing too, since you were talking about like the walk and the power off phase, it's important. I don't know how often you ask, but I ask a lot of questions, anything lower extremity. I like to ask the uphill / upstairs, downhill, downstairs type question.
Yes.
So because like you mentioned on the power off phase, when you're actually loading up that foot to go power off, because of that, we can ask that next level question just to confirm along with the walking and say, like, does it hurt more on your foot to walk upstairs or downstairs? And typically with the plantar fascia, it's going to hurt more going upstairs because then you make that step up on the step above, and then you're kind of creating that same power off as pushing off on your foot at the end there. Versus like the downhill, you could kind of get a little bit more just kind of like letting the foot go through that passive plantar flexion type of movement,
right,
and kind of bail yourself out there.
Yep.
Yeah, and then that's another thing too. Like you're saying first thing in the morning. I don't know, but I want everybody that's listening to this to maybe don't hyper fixate on this, but pay attention the next time you're just sitting on the couch relaxed or laying in bed relaxed, and pay attention to where your foot likes to sit at rest. Because like Rebecca said, we guarantee it's not going to be with the toes like up and the foot up like this. And it's not really going to be neutral either, because a lot of us tend to be a little tighter in our calves and tend to be a little weaker in our anterior compartment with like our tibialis anteriors and our extensor hallucis muscles. That foot, instead of being up or neutral, is going to be actually favored slightly pointed down. And that, again, is just going to keep the plantar fascia adaptively shortened. It's going to keep the calf adaptively shortened. And that's why you wake up first thing in the morning and you go to step, and You know you really have plantar fasciitis, that the classic sign, but not everybody presents with the classic sign, is the when people say, I step out of bed in the morning and it feels like I stepped on broken glass.
Mm-hmm.
It doesn't have to be that level of pain. Like if it is, then you definitely got to get in touch with us. But if it's just a holy smokes, it's tight, yeah, don't let it get to the point of stepping on broken glass, right?
Right. Definitely.
Yeah. So hopefully that was a pretty good breakdown of like our common complaints and everything, right? And we were already teasing a lot of this information, but I want to go into like anatomical connections next. Is it okay if I take the lead on this one?
Please do.
All right. With our anatomical connections, I like talking about a lot of the cross syndromes, right? Once again, as we've alluded to in previous podcasts here, the classic cross syndromes that people are familiar with, anyone that goes to physical therapy, chiropractic, and probably quite honestly massage therapy school is going to learn about the cross syndromes.
Mm-hmm.
So, like, we know upper cross, right, where it's like front of the neck weak, the rhomboids weak, and then the crisscross is strength and overactive on the other end. So, overactive pecs, overactive back of the neck muscles, and upper traps, and etc. Right. Well, once again, there is kind of a little bit of a predictive cross that does live across like that ankle complex as well too. And it's again maybe not going to be so much across. This is going to be kind of the same deal as the knee, where like the overactive, weak are actually going to live on the same side. So if we have, imagine our foot and ankle here on the back, you have the calf, the soleus. Those tend to be overactive, over demanding, and that's therefore going to lead to the muscles kind of on the bottom of the foot, all those plantar surface type muscles, and in addition, like the plantar fascia with it, those are
Mm-hmm.
generally going to be overworked, overtaxed, overactive. And then we've got like a reciprocal weak pattern. So again, the muscles that kind of live on the dorsum of the foot, the top of the foot, are kind of going to be inhibited and shut down more than they need to be. And then the like the tibialis anterior, the extensor hallucis, the extensor digitorum longus muscles, right? For those who really like their anatomy, right? But
Oh
those are
yeah.
basically the three major muscles that are passing from the anterior compartment. And a future conversation, but when people say they have shin splints, they're typically talking about the front of the shin and that pain being there. But I don't
Mm-hmm.
want to get too far ahead of myself here. But those are also going to be weak. So again, we've got like calf, bottom of the foot, overactive, over demanded. Top of the foot, anterior compartment, like your tibialis anterior, inhibited, weak. And that's going to be relevant when we come into assessments and how we treat. But that's kind of what I wanted to go as far as like the anatomical connection. And that therefore ties back into our initial conversation when we were talking about where is the pain, and helps to hopefully illustrate the picture that the pain isn't just going to live isolated at the bottom of the foot. That's why the calf is so predictably going to tie in with that.
Yeah, definitely.
Yeah.
And I will just add to that, and I find it so ironic because I think this is the second time that you're going to talk about muscles and I'm going to talk about joints. But, anyways,
It's fun that way.
it is fun that way. But yeah, the other thing that I really like to do when I'm assessing this is just look at the whole kinetic chain, right?
Yeah.
And especially, so typically in our joints in our body, as we start, if we start at the great toe and we work our way up, right, we should have similar amounts of joint play. But if one is super stiff, the next one's going to be super loose or hypermobile is what we call that, right? So
Yep, that makes sense.
a lot of times what I'm looking at when I have something like a plantar fasciitis or even working up the chain, right? I'm going to look, hey, how is their big toe moving, right?
Mm-hmm.
Is it super stiff? If it's super stiff, then that tells me that probably somewhere up the chain, usually the midfoot, is going to be hypermobile. If that's hypermobile, that's already going to put more of a stress A, on that toe off and that push off, but B, on the plantar fascia in general, because it's going to be flattening that arch and collapsing that. And if you're super stiff in both of those areas, then we're probably going to have some hypermobility in the ankle and or up the chain, right? And that can cause a lot of issues as well. So just looking at that whole picture as we move up joint to joint so that we can actually assess, where that motion is kind of lost and where we maybe need to mobilize, as well as work on muscle tightness.
Yeah, yeah. And now I'm making a note to myself and thinking like a big toe should actually be a topic for us too, because it's just one small joint. People probably don't pay much mind and attention to it, but
So important.
it does so much stuff for you. And I think I've read a lot of literature that says that you're supposed to have like 50 degrees or 70 degrees, excuse me, of dorsiflexion at that big toe during power off. There's way too many people that don't have
Oh
70
gosh.
degrees on that and everything.
There's people that don't have 10.
Yeah. And so if you don't have 10 degrees there, you're going to steal the motion from somewhere else. And like you said, the
Mm-hmm.
midfoot, which therefore means you are over moving that entire midfoot. And
Mm-hmm.
who lives right underneath the midfoot? Hint, guys, it's right at the top here. It's the plantar fascia, right? So then that all just ties into why that's going to be a problem.
Yeah.
Yeah, and you did allude a little bit with like assessments and everything, but maybe just talk through like your gait assessment a little bit and what other types of assessment tools you like to use from um, an athletic training and from a massage therapy school of thought.
Yeah, definitely. So one thing that I always do, and you alluded to gait training, but that's one of my favorite things to look at first is when walk, like just how somebody walks in the door. If you have acute plantar fasciitis, I'm probably going to know when you walk in the door because you're going to be real ginger and gentle in that foot that's bothering you, right?
Right.
So that's usually my first telltale sign. But a lot of times I'll watch people walk, and what I'm looking for again, how does your big toe move? How do your feet move? Do you collapse more on that side that's painful than you do on the other side, right? Um, how does your knee move? Does it move in and out? Am I seeing compensations up at the knee that tells me that your foot or your ankle is too tight or your calves are too tight, right? So I'm kind of looking at all of that. Um, and then, once I get them on the table, again, I'm looking at that joint play. How is your midfoot moving? How is your big toe moving? How is motion in your ankle? I'm assessing, calf tightness, seeing like, are we tighter lower towards the Achilles and the soleus, or is it more tension up at the gastroc where we need to kind of work through that? So kind of just looking at that in general, looking at how they're standing, right? Even looking just with somebody, barefoot in front of me, I can see, are their arches even collapsing even to just support them when they're walking or when they're standing there, right? Does one collapse more than the other? We can look at that navicular, which is one of your bones on the inside of your foot.
Mm-hmm.
I usually just put my thumb on either side and then have people shift weight and watch to see if we get a drop. We call that navicular drop.
Mm-hmm.
That can cause a lot of issues. If your navicular is dropping, that tells me that you have some weakness down here, and that's probably going to predispose you to something like this if you're not having that support in your shoes and in your routines the way that we want to. So that's kind of my take. I don't know if you have anything to add to that as well, but
Yeah. I mean, we look at a lot of that stuff as well too. I mean, always paying attention. I think every physical medicine practitioner is always looking at how their patients walk into the door, how their clients
absolutely.
walk into the door.
Mm-hmm.
And of course, maybe this goes without saying, but we might as well say it too. All of that you just did assessment wise, of course, is with shoe off, right?
Yes,
so
absolutely.
so
Good
yeah,
point.
anybody ever come in and they're saying like, hey, I want to like work and assess on feet. First of all, I think the amount of times that we get like people act surprised where I see it on like the chiropractic side. They're like, wait, you could do work with my feet? It's like, yeah, it's a joint, it's a muscle group, it's part of the
Absolutely, I can.
musculoskeletal system, like we can.
Mm-hmm.
So I think there's always just a little bit of that surprise from people because they're like, I thought you were just a back doctor. It's like we do so much more than that. Like if it's
Mm-hmm.
we're musculoskeletal experts, you are as well too with your massage and athletic training. Like that includes everything, right? So that little ramble aside, I think all of that stuff is great with gait assessment. Definitely fantastic. I definitely put a lot of credence and a lot of stock into functional muscle testing.
Mm-hmm.
And I also really like active and passive range of motion, right?
Mm-hmm.
So I'll first have the patient when they're on the table. The nice thing too is if we do have like a unilateral plantar fasciitis, in theory, your other side is normal. So it does give us like a test control back to the other side to say like, okay, how are you moving on that side? We go to test something like dorsiflexion, and then you come all the way up to here on this side, but you only come to there on that side. Aha, we think we're on to something, right?
Right.
But a lot of range of motion. Usually I'll have the patient try to contract it first, and then I'll add over pressure so that we can test active versus passive. And then it's really valuable to then do like functional muscle testing. There's actually really nice ways that you could set up these muscle tests on the table to more specifically target individual muscle groups that cross that ankle
Mm-hmm.
complex. So definitely testing like the calf and the soleus separately, like tibialis anterior, tibialis posterior. Always gonna do a little bit of like that big toe strength test, and if they have the big toe up and I can melt it down like butter, and that's probably a problem, and that's probably
Mm-hmm.
part of the reason why the plantar fascia is going to be a problem. And then a lot of it is the how we fix it, but I always start with jumping right into the McKenzie exercises and seeing if we get those changes immediately back and all those functional gains that we had. And then, of course, paying attention to how the patient leaves at the end of that appointment too, how they're walking, right?
Yeah,
So,
definitely.
all right. How do we fix it? So some of this stuff has already been buried into the lead here with all the discussion leading up into it. But how about we say some of your favorite techniques, massage therapy wise, and maybe some of your favorite corrective exercises, because I know you love and have a passion for doing that with your athletic training background as well too.
Definitely. So yeah, usually, I mean, we harped on the calves a lot, right? And just muscle tightness, right? So I'm hitting both the gastroc and the soleus pretty hard with my, when I'm thinking massage therapy wise, right? Trying to get that tension down, doing some of that stretching after we test that range of motion, right? Having them do a knee to wall, having them do, like a band stretch with their calf, anything where they're getting that calf muscle to lengthen
Mm-hmm.
after we've done the work that we need to do. Um, and then, I'm also trying to hit the bottom of the foot, right? So I have a lot of plantar fascia stretches that I like to do.
Mm-hmm.
I'm
Mm-hmm.
probably not going to do that with an acute patient because it's going to be really, really painful and you're going to probably not ever want to do them again. But, as that starts to heal and it starts to calm down and get better, I have a lot of things to kind of help work some of that tension out that maybe you can't get out by just walking around, right?
Yeah.
Um, so that's kind of the more massage therapy side of me, is just trying to get that motion back, working on a little bit of maybe joint mobilization at the foot and ankle just to kind of work through that as well.
Yeah.
And then from a like an exercise standpoint, I love eccentrics. So
Mm-hmm.
any kind of eccentric calf raises, right? Or anything where you're powering up and then going slow on the way down, right? So
Yep.
for an eccentric calf raise, right, we're going slow as we lengthen that part of the body, right? So we're going to try and come up on our toes and then slow on the way down. Any kind of thing like that is going to be super, super helpful to just help with that tendon strengthening and tendon healing.
Mm-hmm.
Promotes a lot of issues with that stuff. Um, but yeah, those are kind of my hard hitters with all of that stuff. And then
Sure.
I'm sure you have some chiropractic techniques as well that
Yeah,
you like.
yeah. Well, what I really like, and this is the second time that we've talked through on podcasts and everything, is a lot of the stuff that you say, both like the technique wise, is there's echoes, there's similar things that we like
Mm-hmm.
in some similar muscle fascial tendon groups that we like to go into
Yeah.
too. Sure, we maybe address it slightly differently, but it's still the name of muscle is basically get in there, rough it up, get blood flow. With the blood flow comes healing, healing factors and cytokines and stuff like that, things that are going to help heal the muscle and
Right.
cut down that tension. And a lot of the exercises are extremely similar to what we
Mm-hmm.
suggest. Good movement is good movement, everybody,
Absolutely.
right? You don't have to try to reinvent the wheel, right? um,
I hope
but
not.
but yeah, like anybody who's been following this channel long enough and has listened to me talk long enough knows that the base of all things rehab that I do is McKenzie method therapy. A lot of times, like the vast majority of times with the plantar fascia, people need to do repetitive dorsiflexion. It's getting that dorsiflexion because one, it actually accomplishes a lot of things at once. I'm always talking about like, okay, I'll usually kind of call the plantar fascia issue a derangement at the ankle and kind of give an explanation about like how the ankle is not quite sitting right in space, and this is the direction that's going to recentrate that joint and offload the tendon, the muscle, the nerve, the joint, etc. So that way all your functional baselines come back up and your symptoms eventually improve over time. The reality is if you're doing a lot of repetitive dorsiflexion, you're stretching the calf and the soleus, you're getting a productive rehab stretch across the plantar fascia. No exercise ever exists in a vacuum and only works on one specific thing, but we
Mm-hmm.
don't have to apologize about an exercise treating multiple things at once, right?
Absolutely not.
So it's nice because then if we see that repetitive dorsiflexion is then bringing up the functional muscle strengths that we talked about in the assessment, and we're getting some of that active and passive range of motion back, then we got this thing on the run.
Mm-hmm.
Then I really like a lot of pin and stretch. That's something that I'm going to demo this month with a video, is how to pin and stretch across the bottom of the fascia for the plantar fascia. That's going to really help to not only obtain more of that dorsiflexion range of motion, but really get that thumb contact and drive and burrow into getting that productive stripping out of that tissue. And then a couple of sets of adjustments are really nice. Like it's really good to just like reset the whole joint kinematic at the entire talocrural, like the ankle joint with the long axis. And again, just helping people generally drive a little bit more dorsiflexion. We have like a toggle board technique that we'll demo as well too. Those are just kind of some of the very good predictive things. And then I like a lot of the strengthening exercises you said. Eccentrics are great. After we get people's pain stabilized, some of the other exercises that I really like is actually teaching people how to do constructive arch raises, actually
Mm-hmm.
teaching them how they can do like a 5-step thing to raise their arch and then teach their brain how to lower the arch so they can get that command back over their body. One-legged balances with like hip circles or star patterns while they hold that arch is really good for rehabbing this.
Mm-hmm.
I don't know if you've ever done or have ever seen where you could actually like lay out a towel and have people do like toe scrunches.
Oh, I do it all
Toe
the time.
scrunches it and then push it back out like that. That is
Mm-hmm.
such a good way to just retrain the entire foot intrinsics, because the more you kind of balance out the foot intrinsics, the less the plantar fascia has to take on the full brunt and the full workload.
Oh yeah,
Um,
my athletes do a lot of toe yoga.
yeah, is that what you
That's
kind of
my
call them?
I do, and
Oh,
we'll do a
nice.
lot of like the foot intrinsics where you like lift your big toe and then lift your 4 little toes.
Yeah, that's good.
That's also one of my favorite things to do with that stuff because
Yeah.
it's super helpful.
Yeah, and the well goes really deep. We don't want to like, sit here for the next 10 minutes and talk about that, but
As much as we could.
that's a pretty big overview, and we hope that that demonstrates a lot of the credibility that we have as providers, because that's the reality. Is if you're going to choose to go to Rebecca, if you're going to choose to come to me, then yes, we're still going to do all the things that you would expect Massage Classic and expect from Chiropractic Classic, but we also want to empower you so that way you can have long-term success and actually have control over your outcomes. And a lot of that is just through you're going to have homework. I'm sorry.
Absolutely.
I'm sorry, I'm not sorry, right?
Absolutely.
Yeah, yeah. So, I think we did a pretty good job just unboxing everything with the plantar fascia. Is there anything that you can think of adding?
No, I think we pretty much kind of hit the gauntlet with that one. So,
Yeah, exactly, exactly. I'm sure there's things we didn't say, but even over the course of half hour, there's still some things that we miss, right?
oh, always.
Yeah, yeah. Go ahead and tell everybody where you're at, what business you're with, and maybe how to find you.
Yeah, absolutely. So, again, my name is Rebecca Hall. I am with Happy Valley Bodyworks in State College. We are right down College Avenue, but you can find us online at happyvalleybodyworks.com. And then, Dr. Emery, I'll leave it to you to close this out.
Sure, yeah. Dr. Emery Pitcel, Rothrock Chiropractic and Rehabilitation, also in State College. We are on South Atherton, however, not college. One of the other main arteries there. You can follow us if you found us on this YouTube, but we're also on Facebook and Instagram. Both your company and my company are really easy to schedule online, though.
Yes.
So you don't always have to pick up the phone to call us. You could just, find the schedule online and get an appointment scheduled with us, and
Absolutely.
let us help you get your plantar fascia feeling the way it ought to, right? So
Absolutely.
if this definitely seems like a problem you've had, or a family, friend, or colleague that's struggling with this, please make the recommendation, pass along the link with this, and let them kind of learn a little bit more. And if you need some extra help, we'd be happy to help in a heartbeat here.
Absolutely.
And if this was beneficial, share it, drop a comment to us, and subscribe if you found it especially helpful, right?
Yeah, absolutely.
All right. Well, from April of 2025, hopefully it ends up being a warm month. We know spring is always a little up and down, but hang in there, everybody. It's going to get nicer sooner than later. From our BE school, our Be Better, Be Empowered, I'm Dr. Emery.
And I'm Rebecca.
Yeah, thank you so much. We'll talk to you guys in May.
Thanks, guys.